speaker is Dr. Omar Aboshady, who is a PhD candidate working with Dr. Brian Overholtzer at Purdue University.
Thanks, Sarah. Good afternoon, everyone. I will shift the gear toward non-modeling project, but I'm going to present some of the work we did over the last 2 years to answer, hopefully, partly answer this question. Does pregnancy impact maternal cardiac repolarization? So at the beginning, I will just give some background for some people may not aware about cardiac repolarization. So it is a process that allows ventricular muscle to regain its ability to depolarize again. And it's very important clinical and also drug safety biomarker for arrhythmia. So it is commonly assessed in the EKG by measuring QT interval, as you can see here in the figure on the right. But it's very well known that QT is impacted with heart rate. Higher heart rate will lead to shorter QT interval. So that's why there's different way to correct for that effect of heart rate. The most common one and clinically used is Bazet correction. But as you can see in the figure on the right, that Bazet usually overcorrect on higher heart rate. That's why there are a lot of other different equations came after that. The most common one is Friedreichia, which is most commonly used now in the industry. And you can see the effect of heart rate was almost neutralized. So we also know that QTc prolongations more than 500 milliseconds is associated with 2 to 3 risk of torsades, which is a catastrophic sudden cardiac death due to polymorphic ventricular tachycardia. So when we go to pregnancy, there's a lot of changes throughout the body, including electrophysiology. Actually, the arrhythmia are the most common cardiac complication encountered during pregnancy. And not only that, there are multiple QT prolonging drugs that are used during pregnancy, such as ondansetron and SSRI. So we felt that there is a gap and need to understand more about cardiac repolarization and if there is any baseline change within the pregnancy itself. So when we look at the physiology of the cardiac change that happen in the cardiac during pregnancy, we found that there are some changes that may prolong repolarization. And the other side, there is change that may shorten repolarization. As you can, like for example, the ventricular muscle is thickened by about 50%. Also, there is some electrolyte disturbances later in pregnancy, and the estradiol also is increased significantly during pregnancy, and it is well known that it's inhibit HERG that may lead to prolongation. On the other side, the chronic sympathetic stimulation that affect the expression of HERG, that also may lead to shortening, and also the progesterone, which has opposing effect compared to the estradiol. So the question now, what is the net effect? Is it the same, prolonged, shorten? When we looked at the literature, we found inconsistent result. However, there was a consistent evidence from the long QT syndrome patient who are the patient have a genetic mutation in HERG, and not only HERG, but ion channels responsible for repolarization. And we found that the risk of cardiac event decreases during pregnancy, and then it spikes 12 times postpartum. So there's something happening in pregnancy compared to the non-pregnant state. So last year, we did publish a systematic review and meta-analysis to try to quantify what's going in pregnancy. So we found that there's 33 studies assessed both pregnancy and non-pregnant. So we captured the pool mean difference between different trimester and non-pregnant women, and we found that there was a statistically significant QTc lengthening, but all this study used Bazet. And we know that the heart rate is increased during pregnancy. So is this really due to the pregnancy or the overcorrection from the heart rate, as I mentioned previously? The second question and gap we couldn't identify in that systematic review, that there is no measurement for the effect of sex hormone. I just mentioned that estradiol may increase, progesterone may decrease. So there is no assessment for the relationship between the hormone and QTc. So that led us to conducting BREAKHEART study. It's a prospective clinical cohort pilot study. And today I will present some of the preliminary results. So we recruited 40 healthy pregnant women, aged more than 18 years old, in the second trimester between 18 and 22 weeks gestation. And you can see here some of the exclusion criteria we applied. So in this study, each woman underwent 3 visits throughout the pregnancy. The first visit between 18 to 22, the second visit was in early 3rd trimesters, and the third visit was after 36 weeks, late 3rd trimester. At each visit, we did 3 12-lead EKG, and also we measure the sex hormone and metabolite, and also we did genotyping, but I'm not presenting today. So I mentioned we recruited 40 participants, out of which 37 participants completed at least 1 visit, out of which 27 completed the 3 visits. And to compare in pregnancy, it's always challenging to have this woman before pregnancy. So we use the most common approach, like to use historical non-pregnant control. But fortunately, our group did 2 studies over the last 10 years in premenopausal healthy woman during the menstrual and ovulation phase. So we have 31 patients. We have EKG and also the hormone concentration. Because we know EKG, like the QT, have a lot of variability, so we wanted to capture also some of the variability in the QTC. So we did a systematic review to capture all the published study that reported QTC by Friedreichia in premenopausal women, which identified additional 3 studies. So in this table, you can see the demographics between our pregnant cohort and non-pregnant cohort, and they were very comparable, except that our pregnant women had higher participant in Black population. And as expected, the QTC correction by Bazet was overcorrecting for heart rate, which was not the case for Friedreichia. So we're gonna move forward with Friedreichia. So when we compared the individual participant data between the non-pregnant and pregnant, there was a statistically significant shortening in QTCF across the trimester, and also the pregnancy, it was stable for QTCF. When we used the Boole effect from the meta-analysis, we still see this statistically significant trend of shortening compared to the non-pregnant control. When we assess the relationship between the QTCF and hormone, specifically progesterone, estradiol, and the ratio between progesterone to estradiol, we found non-significant correlation, negative correlation between QTCF and progesterone, and also the ratio between progesterone and estradiol in pregnancy, which is in line. But you cannot, in the middle, the estradiol seemed to be flattened, despite that in non-pregnant women, which is in gray, it was showing increase. So with this preliminary data, our conclusion is that there was a significant QTCF shortening, which is in line with the clinical observation in long QT syndrome patient. And probably there may be a role of progesterone and the ratio between progesterone and estradiol. At the end, I want to acknowledge all my mentors and also all the colleagues I worked with over the last 2 years. Thanks so much.